Hi guys, Bevan Collis here from the Knee Gurus and Asia Physio, and today we're going to talk about clinical testing of the knee. So what is clinical testing? Clinical testing is basically a physical assessment, including special tests that your physician or therapist will do on your knee in the actual clinic, on the treatment table and around the treatment table. With the advent of MRIs, clinical testing has lost a little bit of popularity and some health professionals don't even bother doing it. But I still think it's a critical part of the overall picture, and we don't really get a full picture of what's happened to your knee just from images. We need a couple of images with a proper history and a competent physical examination, including clinical tests. So we're going to run you through the main clinical tests for the knee today, testing for a lot of the major or common injuries in the knee, ACLs, MCLs, meniscus. Explain to you what your therapist is doing, why they're doing it, and what they're looking for. So let's get into it. Okay guys, so I'm going to show you how we do a clinical assessment on a knee. So first, when we have a patient on the table, it's very important that they're comfortable and relaxed. So make sure they've got the right amount of pillows. We've got a little rolled up towel under the knee. The heel is actually on the table, not hanging over the edge, and you're making the patient feel relaxed, because if a patient's tense and wondering what you're going to do, your clinical tests aren't going to be as reliable. Okay? So first of all, a good, easy test to do first time you touch the patient is a test for extension overpressure, which means we can just pick up the toes, hold them up there, and just see, is that painful at all? So it's not painful. If it was painful, that's giving us a slight positive to the meniscus injury, because as the two bones come up and push together, if the meniscus is torn, that's going to cause pain. All right, the next clinical test I want to run through is called the Lachman's test, and it's a test for the anterior cruciate ligament. So in this test, it's really important the patient is relaxed. Okay, so what you want to do is try to distract the patient almost. Don't tell them that they're about to have a test done on them, and don't tell them that the test is going to be painful. Number one, because generally, if you do it well, it's not painful. And as soon as you start to warn the patient, if you say, okay, I'm going to do this test, it's going to be a little bit sore, but don't worry, it'll be over quickly, the patient tends to tense up and you can't get the results that you're after. So just relax. You can speak to the patient about what they're doing and what their plans are. Now, as far as doing the test well, I like to do it, and I always teach my staff to do it with the knee under the thigh. We want to stabilize that femur as much as we can and stabilize it in between the knee and between the webbing on your right hand. When you're pulling on the lower leg, it's important not to dig your fingers into their calf, because that'll cause pain and it'll cause them to tense up. Okay, so use the flat padded parts of your finger. Try and grip as lightly as possible there. You don't want to grip tightly, so it's going to cause pain. So a nice light test. Now the key to getting a successful Lachman's test is to be quite quick with the pull. So what we're doing is jerking forward on the tibia to pull it forward, and what we're looking for is a hard end feel. So we can see there, trying to keep the patient relaxed, keep it stable in the femur or the thigh, and pulling forward like so. And we can see nice and easily that there is a hard end feel, which shows us that the anterior cruciate ligament is okay. Sometimes you might need to do that test repeatedly until the patient relaxes. Sometimes you might even do it 7 or 8 times and the patient is tense and you're not getting to the end of the length of the cruciate ligament. But then on the 10th time, you'll catch them relaxed and you can get a positive test. And that's all you need, that one solid clunk. So with the Lachman's test, what we're testing is this anterior cruciate ligament, the main rope-like ligament that runs through the center of the knee. We're jerking forward on the tibia nice and quickly, and when that ACL comes to the end of its length, we should get a nice solid clunk. It seems like a really simple test, but it's actually very reliable, and most studies show that a Lachman's test done by an experienced practitioner is about as reliable as an MRI. So another test for the ACL is the Anterior Draw test. It's not quite as reliable as the Lachman's test, but some people who have smaller hands have a bit of trouble with the Lachman's test for getting their hands in the correct position. So this one's a little bit easier to do for the practitioner, but not quite as reliable. So this one we want the hip at around about 60 degrees and the knee at 90 degrees. It's a good idea to sit on the table and just put their foot underneath your leg to stabilize. So once again, we don't want to push in and cause pain on the back of the calf there. We just want to stabilize, and once again, do a quick tug. It's got to be quite fast. If we do it slowly, we don't quite get to that hard locking, snapping end feel that we're looking for. So quick tug, and we don't want it to translate more than about 6 mil, and we're looking for a nice, strong, tight end feel. If we feel that it's coming forward a long way, more than it should, then that's a sign that the ACL is ruptured. Okay guys, next test I want to run through is the Valgus stress test, which is a test for a tear of the medial collateral ligament, or the MCL, this ligament running down the inside of the thigh there. Once again, it's important to have the patient relaxed prior to doing the test. A few different ways to do this test, but as long as we're getting a good valgus force or inwards force on the knee, we're going to get good results. Some people like to do it like so, standing down the edge of the table and putting the force like so. And what we're doing is stretching the MCL there. We do it at 30 degrees as well as at full extension, like so. And we're looking for pain, if the person's jumping or if that's sore. And we're also looking for laxity, how much movement there is as we put that force through there, because if there's laxity and if there's more movement compared to the other side or compared to normal, that means that the integrity of the ligament's been compromised and it's a higher grade ligament, a grade 2 or 3. We can also do it in this position here with my thigh under the leg of the patient and grabbing around the heel there. 30 degrees and 0. So if it's painful with no laxity, then that's generally a grade 1. If it's painful and lax, we can feel that extra movement compared to the other side, that's grade 2. Should always check the other side. And interestingly, if it's extremely lax, there's a lot of extra movement, it feels like the gate's opening more than it should, and it's not painful, or the patient's quite relaxed and there's no real pain, then there's a pretty good chance that's a grade 3, which means it's a complete tear, because the grade 3s are actually a bit less painful than the grade 2s, because there's no ligament left to come to the end of, and the nerve fibers can be a little bit damaged. So the grade, just because it's not painful, doesn't mean that it's not injured. Okay, so now I'm going to run through a couple of tests to see if somebody's damaged their meniscus or not. So the meniscus is a shock absorber that sits deep inside the knee. And one of the best ways, probably the best way to do a clinical test for the meniscus, is simply palpating on the joint line. So once again, it's a good idea to get the knee in that 30-degree position. And we want to try and find where the joint line is. You can feel where the top of the tibia ends and the bottom of the femur ends. And there's a little line in between there, which is the joint line. Now, most meniscus, if they're damaged on the medial side, as well, palpating here will cause pain. And I think, and statistics show, that it's the most sensitive and reliable of meniscal tests. You can also palpate on the lateral side as well. Just got to be careful in that the medial collateral ligament, or the MCL, does cross the joint line. So if it's torn at the site of the joint line, that can be painful as well and give you a false positive. But it's always a good idea to have a good palpate on the joint line to see if there's pain there or not. Next test for the meniscus is the McMurray's test, which, once again, it's important to have the patient relaxed. We grip the heel like so that we're ready to put a little bit of compressive force, like so, down the shaft of the tibia, and put some counteractive force there on the top of the knee. And we're just scooping like so. So we're pushing the bottom of the tibia up onto the femur, and that'll often produce some pain. We can change the angle to test the medial or lateral meniscus. Once again, we've got to be careful we don't get a false positive, because sometimes as we get in there and compress the medial meniscus, we're also stretching the MCL. So sometimes a torn MCL can cause pain there as well. So just be careful of that. Okay guys, another clinical test that we commonly do is called the patellar grind test. And what this is a test for, to see if there is any damage to the cartilage that's sitting underneath the patella or the kneecap. It's a really common site of cartilage damage. So what we want to do is move the towel out of the way. It's a really simple test. Got to do it correctly though. Keep the knee in full extension, put the thenar eminence, or the sort of bulky part of my palm, and push down a little bit side to side and up and down. We're just basically grinding the patella on the notch at the bottom of the femur below. Now if that notch has got cartilage damage, or the underside of the patella has got cartilage damage, you're looking for pain, as well as any sort of crepitus or grinding sounds. Normally if people have got cartilage damage there, this will be quite painful for them. So we're looking for pain and also sounds and cartilage. And you can feel how free the patella moves. Is it really tight and stiff, or is it quite mobile? That's the patellar grind test. So the important thing to remember for all these clinical tests is always compare both sides, because some people are just naturally more flexible and have naturally more laxity in some joints, and some people have naturally less laxity. So every test we've done, we always should come around and do it to the other side, the same that you did to the affected side. And remember, clinical testing is an important part of picture, but it's not the only part. There's still a lot of importance in imaging, history taking, and subjective findings. They all come together to form the overall clinical picture for that patient. Thanks for watching guys. I hope you found that content useful and gave you a bit of an understanding about the importance of clinical testing. If you liked the video, remember to hit like and subscribe, and keep an eye out for more content on our YouTube channel, as well as checking out our podcast on the Knee Gurus. See you next time.